on. If you do this cerclage, the patients will have to have a cesarean sections when she's pregnant. But very often patients are very keen to have that due to the problems there. So first of all, the classical one, based on cerclage, on this small video. I'm sorry the screen is not very good, so you can see very well. We start to see the uterus is in the below. So let's start again the video. So we start by opening the anterior cul-de-sac. Sorry, the video is starting again. So we start by opening the anterior cul-de-sac between the bladder and the uterus. Since the aim of this cerclage is to make a mesh around the isthmus. So the difficult part of this this technique, this conventional technique, is to make the funnel between the uterine artery and the uterus. Because the risk to have hemorrhage is quite big. So you see we have the isthmus which is there. Here. And so you have to go around with your mesh in order to make your cerclage. So we have to dissect to make the funnel. You see here we are trying to do the funnel behind the uterus. And so when you do that, it is quite time consuming. You have the ovary on the left, the tube. And we have to put your mesh between the uterine artery and the uterus, because if you do that outside of the uterine artery, the risk is to create insufficiency of blood supply of the uterus during the pregnancy. This is why you are ready to stay close to the isthmus. Okay, so we have to go ahead, and now we see the mesh. The funnel has been made on every side. Then we have to make a good position of the mesh. And then we have to knot the mesh inside. So in itself, the technique is not a very complicated one. The point being to do a good dissection laterally to the isthmus, where the bleeding is something which is something to avoid. That's the knots, and then the technique is almost finished. So when we do this technique, it takes around 45 minutes, something like that, due to the dissecting time, which is quite long. You have to cut the mesh and to close the peritoneum when it is finished. So then we try to see, because we have the impression that it was a good technique, it was simplified, to propose the simplified technique by laparoscopy. There was the percutaneous technique, which was already described by Miyajima in 2003. We modified this technique to have a simple one. We try to show you that. Okay. So once again, we start with the same approach. It means that you have to open the anterior cul-de-sac. So we open the anterior cul-de-sac. I'm sorry for the quality of the imaging, but the screen is not appropriate, so I cannot see correctly what we do. use the monopolar to avoid bleeding. It is very important to try to minimize the bleeding in this technique. So we see we start exactly as the previous technique. Just a limited dissection, so small polarization if you have some bleeding. And then it is one where we change the technique. So first of all, we are going to put the, you see that it is the uterus. Sorry, so we put the mesh in the push of the glass, ready to be used. And then now you use a percutaneous technique. We have a needle. You see from the abdomen, and we go straight laterally to the isthmus. So we have no dissections to do. You see, this video is almost in real time.
الشيطان الرجيم بسم الله الرحمن الرحيم أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وضعها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو العصف والريحان.
We do the same process on the other side. This cerclage is already high. It is just above the plan of the uterosacral ligament. You see the needle once again is open. The nail of the needle is closed, the underclose. You see that it is a very quick technique. Made some editing in the video, but all the procedure in these patients took less than 10 minutes, which is important when you propose a technique like that for the patients to be sure that it is a mini-invasive and safe technique, and then we are again to do the knot, as you have seen in the previous video. The technique is the same. So we usually make 2 or 3 knots. After the first one, you hold the knot to be sure to have no leakage, and then it is almost finished. We have to say that in the uterus we have a dilator, because we do that before the pregnancy, but the dilator inside the uterus is in case of early miscarriage. We are able to do a curettage or aspiration without any problem, because the aim of this cerclage is not to close totally the cervix, but to just give support for the baby. And then it is almost finished. Then we have to cut the mesh, and then to make to close the anterior cul-de-sac. And we just close the anterior cul-de-sac with a quick 0 with a rolling suture. And you will see the end result. So this cerclage is definitive, so we have to do C-section after that, and we already have patients with 3 C-sections. It means that you can have several pregnancies if you wish after that. It's not a problem. The indication is that to take to the obstetricians to make the C-sections just above the mesh. So we remove the dots, and then it is the definitive aspect. You see, we cannot see the mesh at all. Just look at, and then it is finished. So now if we want to review the literature, you see we have some small series of patients. The first one from Benson in 1965. You see that before the pregnancy and after, before the surgery and after, the result in terms of pregnancy was quite good, between 69 to 93%. And in all, 84% of patients were able to reach the pregnancy after 34 weeks, which is not too bad. Another paper, more recent, 2011, to compare the effectiveness of abdominal cerclage versus laparotomy versus laparoscopy. You can see that we have 6 studies, laparoscopic approach in 135 patients, 26 studies abdominal approach, which is more than 1,000 patients. And you see that by laparoscopy, we have almost 80% of patients who can achieve a pregnancy more than 34 weeks. But laparotomy is a little better, 84. But the last of third trimester, no, 0 in case of laparoscopy, 1% in case of laparotomy, which means that in fact it is not significant and we can consider that the results are in fact the same. Another paper, post-conception abdominal cerclage by laparoscopy or laparotomy, more than 600 cases in 16 studies, similar success by laparoscopy or laparotomy. No difference. This no difference if the cerclage is practiced before or during the pregnancy. With that is something which is debatable. Then, what is the best? I show you the next 2 kinds of cerclage, abdominal and vaginal. So there is only one paper we demonstrate that the abdominal one seems to be better than the vaginal one. Very recently, we see a paper, it is a retrospective study in 2 centers, one in Amsterdam and in Boston, with quite a lot of patients. The inclusion criteria was that only patients who have at least one late miscarriage or incompetent cervix. You see that the mean operative time is very different if you are before the pregnancy or during the pregnancy, because before the pregnancy they have mean operating time of 52 minutes, and during the pregnancy, 71. Also very good result because they achieved to have 96% of pregnancy rate after 44 weeks. So you see that really it is a difference, and in our serie we have seen that if you do that during the pregnancy, it is much more difficult because there is more bleeding, it is more supple, it's less evidence. So we try to do that, if possible, before the pregnancy. Then you have to, if you have to choose between all the cerclage, supracervical or abdominal, we consider that the best approach is the supracervical. We have to do that by laparoscopy, not laparotomy, which is too invasive. And what it is the most important thing is to use a mesh, not a simple thread, because if you use a thread, you will cut the risk to cut the isthmus. So really, we have to use a mesh. Our personal serie now about 54 cases. So between 2004 and 2008, we did the classical approach. Last, like I show you in the first video. And then since 2004, we do the simplified laparoscopic technique. And we have 47 patients, 5 during the pregnancy. So you see, we prefer to do that to do outside of the pregnancy. And we see the delivery. We have 52 patients who deliver after 6 weeks of pregnancy, 2 between 36 and 32, and we have 2 failures. One was a patient with a twin pregnancy, and we do that during the pregnancy, and we have a failure at 20 weeks. So we repeat again, and unfortunately, she has a baby after 36 weeks after the second cerclage. We have recently 1 patient at 70 weeks because there's contractions, during contractions we cannot stop, and then we have to remove the cerclage that it is a second failure. So you see, in all, the results are quite good, but we have to tell the patient sometimes we may have also some failure, okay, we say surgical procedures. So we consider today that the indication should be more on large. First of all, we have the classical one, it is a cervical incompetence, but we have to know that sometimes the cervical incompetence, you cannot detect it before the pregnancy. We have a lot of patients with, if you test the cervix, it seems to be okay, and during the pregnancy, unfortunately, the cervix will be open. We consider the new indications with that in my serie, we accept now to have patients with only 1 or 2 late miscarriages, because if you say to a couple today, okay, we have one late miscarriage, wait for the second one, after the second one, wait for the third one, I think it is impossible to do that today. The information, of course, is critical. We have to tell and explain to the patient that the C-sections will be mandatory, and that it is something where the patients are quite keen to accept. We have to probably to be very clear, which means that today in medicine it is a shared decision with the patients who can propose that, but very often patients are very demanding due to the burden of this kind of dramatic accident. Still some questions. When? So I just answer without saying that I prefer in my serie to do that before the pregnancy. It is much easier to do. The complications seems to be very rare. Surgical complications seem to be very rare. Fortunately, now clearly we have no complications. I know there is some described in the vaginal approach with some hemorrhage. I think we should perform a systematic hysteroscopy during the procedures, at the beginning of the procedures, to search for the chronic osteoarthritis, because that is something which could be a problem during the pregnancy. A lot of patients after a late miscarriage will say, okay, you have chorioamniotis. In fact, it is something which is debatable because sometimes the chorioamniotis can after the opening of the cervix. It is not the cause, but the consequence. But to be sure, probably patients with chronic osteoarthritis are at risk to develop a chorioamniotis during pregnancy. So it's good to say that before, in case of chronic osteoarthritis, to treat them with antibiotics for 1 month. How is the pregnancy with the cerclage? In fact, it is a normal pregnancy. We can say to the patient, you can have a normal life. Of course, after this kind of accident, patients are quite keen to be very cautious. So probably we have to tell the patients don't do much big effort. But it is not a problem, and we have most of our patients have a pregnancy which is almost normal. So that I will finish that and to say that this cerclage, I think, is already a hope after a dramatic accident like late miscarriage. And I thank you very much for your attention. If you have any questions, I will be Yes.
Thank you for your excellent presentation and the technique. Actually, I want to ask you that the mesh places under care anesthesia, and after delivery of baby, you remove the mesh or you keep it for the next pregnancies?
No, we leave the mesh in place, and already we have patients with four patients with 2 pregnancies already with the mesh, and 1 with 3 babies after the mesh. So we leave the mesh for life, not a problem. The only thing is to make the C-sections just above, not to cut the mesh. So we have to tell to the obstetrician, be careful, we have a mesh, so we have to stay just a little above.
And also, prior to pregnancy, how many months ago actually did you put the mesh? Prior to pregnancy?
Before pregnancy, yes.
Yes, and when exactly?
She can be pregnant 1 month after.
1 month.
Yeah,
Okay.
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 That's what. The next cycle is okay.
Okay. Thank you.
I know I just, I was surgical once, long time ago. So how do you secure that you still have an opening to the uterus, access to the uterus? So you are using some kind of this.
Dilator. So we put, at the beginning of the procedures, we put the dilator, EGAR
For what size?
number 8, which is quite big, to allow to have aspiration up to 12 weeks, which was sometimes the case because, of course, we don't want to stop the early miscarriage with our genetic causes, most of the cases. We only want to treat the late miscarriage.